Yeah, Jonathan, thank you very much for introduction, and the panelists and co-chairmen, ladies and gentlemen. So I'm glad that we have a webinar on polytrauma in children, which of course is a special entity, and it's very different in some institutions. You have the children with you in the trauma room, in others you might not have this separately. So my first talk will discuss a little bit the situation in the emergency room and the necessary requirements there, and also some of the injuries that are not covered by the other speakers. Actually, I have to continue. So actually, what are the differences between the children and the adults? Of course, it's the size, the surface, and also the type of injuries and sometimes the therapy. You all know there are guidelines, and 2 years ago we published in the European Journal of Trauma and Emergency Surgery the level 3 guidelines for treatment of patients with severe trauma, with the whole literature at this time, and also in part children are covered but not completely, and in many countries like in Germany we have now established guidelines polytrauma treatment in the children, which is at the moment unfortunately only in German, but maybe there are also others. So what are the injuries we have to deal with? This is from one co-worker of mine, Maika Ford, evaluation of a 5-year period about all children presenting in the trauma emergency department. And these have been 15,000, and these have been evaluated. And we found actually between the group of 1 to 3 years, about 3,500 patients, the same 4 to 7 years, and 8 to 12 years, and also above 13 years. So a similar percentage of patients with all types of injury. But when you look about the age, you see the blue bars are the very small children, and also in the group 2, 4 to 7 years, the head trauma clearly dominates the injuries, which are often also very soft contusions, but the reason for presentation of head trauma is very high, while other injuries, for example, of the ankle or the hand, can be observed later on. When we look now, and this is the reason for this presentation today, about severely injured patients, and then you see only 1, sometimes 2 children per month. So this is our own study from ourselves, and the recent years it was not really different. And if you look at US data, you see that you have 3,000 patients above ISS of 24 and 10 years in 50 trauma centers. And if you calculate this down, you are by 6 children per center per year. So obviously similar data. And also an Australian study of 2005 shows that you have to see about 1 to 2 children with the ISS above 15 every month. So it's not so often also in the larger trauma centers, but these children where we discuss now are severely injured children. Also, we looked about our German trauma registry, also a co-worker of mine in 2010, about the pre-hospital and early clinical care of infants. And this have been almost 3,000 children of the German registry, which is only with highly injured patients that are included in this register. So it's a bit older, this study, but patient distribution, you can see here that of this 25,000 injured persons, 21,000 have been older than 18. But if you look about the small ones, you see 0 to 1 year is 0.5%, then you have 1% to 5 years, and 2% in the other age groups, and it's increasing after the age of 13. So that means that the very small children are not very often with this numbers what I told you. When we look at our data, at this time in these age groups, we had in adults a mortality of 11.4% and a 6% mortality within the first 24 hours. So this is almost average in Germany for severely traumatized patients. The ISS in these older groups was about 26, but if you look in the younger group, you see the very small children have even a higher mortality as well overall, and also in the first 24 hours. And then it is age between 6 and 13, it goes a little bit down, and then with traffic, it goes again up. And the first two groups are clearly from brain injury. And if you look at the pattern of injury with the AIS score of 3, you see that in the children, initially you have 2/3 until the age of 10 with predominant brain injury. This is head injury, and then increasing injury of the extremities and of the thorax, and slowly of the abdomen. So again, the brain injury is in the very small children very relevant, and the older the children are, the closer the injury pattern like in adults. So what is the criteria for trauma team activation or shock room or emergency room? How do you call it in your country? This is quite clearly, like in adults, injury pattern, and in particular TBI and falls. And then you have the vital signs which determine whether a patient goes into the emergency room, and also, of course, the falls and the collision. And then the trauma team is activated. I think this is mostly the case in the trauma centers, and also we have level 1, 2, and 3 trauma centers, but it has to be in all of these levels. And if you have a level 1 trauma center and you know that the children is coming, you have to activate as well the pediatric surgeon and the pediatric intensivists to take care from the first minute with the small children. This is a procedure which has been very well established and is very helpful. In particular, the smaller the children are, the more relevant is. The next step is if the such a small patient, like older patients, is presented in the trauma room, like here, then first you have a standardized turnover. That means that for a moment there is some quietness where the rescue team reports to the accepting surgeons what happened, what they have done, what they have given, and then the treatment can start. Otherwise, if this does not take place, you get loss of many informations, and this should not take a too long time. And then a parallel workflow starts within the anesthesiology, surgery, radiology, and in the children, of course, with the anesthesiology together, the pediatric intensivist, and in the surgery with the trauma surgeon, also the pediatric surgeon, and you follow our well-known primary survey with all procedures that are required. And some differences are, for example, the venous access, which is sometimes more complicated in the very small children. And if you see here the intraosseous administration of fluids into the tibial head is very easy applicable also at the scene and in the hospitals. And then later on, the regular arterial venous line can be included. It's good to know that with this intraosseous line, you can also perform a CT scan with contrast media. It's sufficient enough, and we have done this in several cases. So the first critical point between airway, of course, is the pediatric hemorrhagic shock. And it's one of the main causes of preventable death initially, in contrast to the brain injury, which is a little bit different. And some concepts in adults like permissive hypotension, restrictive fluid resuscitation, just to avoid larger bleeding, are not really studied in children. So they cannot really be recommended because there are no prospective trials, to my knowledge, in this field. And in children, there's another situation that the children remain pretty long time normotensive with a good blood pressure and circulation, even if the blood loss is about 40%. Then they can very rapidly deteriorate of hemodynamics, and then everybody is in a hurry. So one has to know this, one has to start with the treatment early enough if one have the situation of bleeding control or bleeding anyway. The first line, like shown in this scheme published in 2018, is of course the substitution with crystalloid fluids with a bolus of about 20 milliliters per kilogram. And if this is refractive and has been repeated for some times, one has to consider no epinephrine or epinephrine. And even if this is not the case, one has to go to transfusion if necessary. And in children, we would recommend to have a hemoglobin above 8, at least not to go too rapid down, because the compensation is long, and then you cannot come across with your substitution. So this shock therapy starts already at the scene, or at least in the trauma room. And then in the trauma room, of course, you need some technical equipments like intubation, ventilation, you need ultrasound, you need an X-ray or digital X-ray, and actually also options for surgical intervention if the very rare case that you have to do emergency laparostomy or thoracoscopy. And close to the trauma room, you need a CT scan. So in the new modern buildings, we all have the CT scans, at least in the trauma room or immediately adjacent to the trauma room or in close vicinity, so that you can very rapidly go to the CT scan if you have enough indication for this, where I come later on to. So another requirement is of course the ultrasound, which has to be done in the first minutes after arrival, and where you can see the parenchymal organ injuries or fluid in the abdomen, or even more if you're experienced. And also in a really traumatized children, the X-ray of the thorax, and in very small children, you have an X-ray of the thorax and the abdomen and the pelvis in one image. Is also mandatory to have some overview what have happened in the children. So on the left side, you see a lung contusion in a 9-year-old girl, and on the right side, this is a 4.5-year-old girl where we had already inserted a chest tube, which had lung contusions, what you can see in the middle image. So these are two different children. And also, beside the ultrasound, of course, where you can see the fluid in the abdomen, but sometimes you don't see really the parenchymal reason. So in these children where we perform a contrast-enhanced CT scan, you of course can see such a large degree splenic rupture, which will be in most cases treated conservatively, but this is only possible if you can stabilize the circulation, if you can perform the stabilization of the coagulation, sometimes the transfusion. So the primary goal, where we later on is probably to keep it. And a major point initially is, of course, the CT scan of the brain. So in the children like here fall downstairs with a Glasgow Coma scale of 6, you of course need a CT scan and you see this large bleeding of subdural and epidural hematoma. And the requirement is as soon as possible, that means immediately after the trauma room, the hemicraniectomy, because this is the only chance at all. But like in this case, still hypoxia remained in these children, even if it's a very quick procedure. This is another case of a 5-year-old boy. He's fallen from outside the third floor from the window, and we had in the initial CT scan large bleedings here, and of course a low classical coma scale, and we went immediately for hemicraniectomy. You also see here the fractures, the hemicraniectomy, and the decompression. This patient had some disability and went to neurological rehabilitation, but this is the only chance for surviving, to have a very early hemicraniectomy. I know that the neurosurgeons are sometimes a little bit hesitating to do it, also in bifrontal hemicraniectomy, because you get the extra herniation of the brain, which also may cause problems. And nevertheless, the TBI is the most important point, and the risk for children to get that. It's in 80% of the children, and you have to take all procedures just to avoid secondary brain injury, hypoxia. And this is an example of a 13-year-old child who had some hematoma deep here in the brain, but after several days, he had neurological deficit, and then you see in the MRI much larger injuries than you could imagine in the initial injury. So the MRI in children is also an option, but not for the immediately resuscitative emergency room treatment. So there's always a discussion about radiation exposure in children, and you always have discussions with the pediatricians. But there's no doubt that if you have an adequate trauma, you need a CT scan very early and very rapid, and also with contrast media for the brain without contrast media, but for thorax or abdomen with the contrast media, and also for all other injuries you may have. And there are protocols which are important for your radiologists, that you can reduce the doses of the CT scan by some interscalated protocols. You can really reduce the doses also to the brain. You have to protect as much as possible the eyes, that means the lens, and it could be shown in several studies. Here's only one study that you can reduce the lifetime incidence of carcinoma, thyroid carcinoma or leukemia, and the radiation exposure, but without missing important information. So one has to consider really the good protocols. So lastly, I would like to shortly mention the management of pelvic trauma, because this is one of the other reasons for severe bleeding in the children. If you have not bleeding brain injury or thoracic abdominal injury, and you have sometimes bleeding from the artery and the veins, and it's not so rare that children are overrode by tires, like you see here, where you can see either easy fractures of the ilium in this case, or where you can perform a conservative treatment, but you need a CT scan, you need a bleeding control. On the other hand, you might have open book fractures like here in this case, and it's easily possible to perform an external fixator of the pelvis. In this case, you had an additional femur fracture, which was fixed with a ASIN procedure, but also you can have really severe type C injuries of the pelvis, like here in this very small girl of 3.5 years, which we treated with an external fixator, which had really also a rupture of the urethra in this situation. So pelvis fractures are also an important reason for early hemorrhagic shock. I think I have given you a small introduction to the topic. Thank you very much.
Thank you, Ingo, for that great, I suppose, overview as a sort of tour de force. Can I ask you a question about your trauma team activation? The impression I got from your slides was that you activate your trauma team with a Glasgow coma score less than 9 and some other sort of fairly scary vital signs, vital parameters. Presumably, when you're talking about activating your trauma team, you're talking about something fairly different to what I would mean in the UK when we activate our trauma team, because we would activate on a much, much, much lower threshold than that. So when you're activating your trauma team, what does it consist of?
Well, actually, maybe this was a little bit wrong in that figure with the Glasgow coma scale below 9. So actually, the trauma team is activated for any children that comes via helicopter or some other car in the trauma room with a history of severe injury or any problems with circulation or respiration. Yeah. So every admission to the shock or trauma room gets the activation of the shock room trauma team. Yeah. And the first slides where I showed you these 15,000 people, these are all patients that are coming into our emergency department for trauma. But the severe children that usually fall from heights or are overrolled by car or something like this, they come to the trauma shock room, we say, and for our department, we have about 550 activation every year, but of them are about 200 ISS score, about 16 or 20. Yeah, and so this is not every day. This is, I told you, twice a month, maybe 4 times a month. Yeah, because sometimes the children are not as severe injured. Yeah, and this is only for the severe cases.
Okay, thank you. Can I open this to the panel for comments? Paul, do you want to say anything?
Well, Ingo took some of my good points from the next lecture, so that will be a short one. But I completely agree that you need to have some over triage, so to say, to be sure that you don't get in the opposite situation with under triage. So even though in our trauma center we see 1 to 2 severely injured patients per week, but we have 370 trauma team activations in children. That's on average 1 per day. So about 20 to 25% are actually has an ISS over 16. So I completely agree with Professor Marzi in that you need to activate your trauma team based on certain criteria, and you should actually have an overcharge. I think that's to err on the safe side.
Yeah, Paul, so maybe I can answer. So we looked in a study 2 years ago about our over triage, because this is a discussion, because some people complain that we activate too many teams for adults more than for children, of course. And actually this has changed the last 10 years. Yeah, so about 10 years we have, I think, of 2 admissions, one with the ISS above 16 or something. Yeah, now we have 5 activations for 1 or 2 patients. Yeah, so the situation is that we rather more often activate the trauma team. Yeah, and but maybe I'll ask you later the question about CT scanning after your talk. Yeah, okay.
Okay, Thomas, do you want any comments on the pelvic injuries, perhaps?
Yeah, I think that's that's very important as well. And we did during my time in Frankfurt, I looked especially at the algorithm that we use in adults for patients with pelvic injuries, and I think the same is absolutely true as well for pediatric patients. But it's just important, as Professor Marzi already said, that children will have quite a good hemodynamic status initially, but then they can deteriorate quite fast. So that's, I think, is a point that we always should consider. They can have really severe pelvic injuries and they keep quite good initially, but then they can really deteriorate fast.
Okay, right. We have a couple of questions from the audience. First one is, during the COVID situation, have you seen any reduction in pediatric trauma admissions in your emergency department and trauma center? And if so, is the severity any different now to how it was before COVID?
Actually, we have not counted really, but I would say during the COVID situation, we had, of course, overall much less trauma patients, of course, but severe trauma also went down, but it's remained still at a higher level. And I could not say that we had much less children. Yeah. So the severe trauma was reduced, but not as strong as the regular trauma. This was, of course, largely reduced, going to zero, actually. Yeah. But the major trauma was actually still relatively high. But I don't know the numbers of children. I don't think it's too different.
Okay, the second question, I'm not quite sure I understand it, but would you consider performing only a fast exam in hemodynamically stable children, even if free fluids are seen? Or would you always make a CT scan if free fluids are seen on the fast?
Yeah, actually, yes. Yeah. This is a question I would like to discuss after the next talk of Panellist, because it's this topic, because it's the ongoing discussion if you have a fast and still do a CT scan or not, but it depends on the whole situation. So if you have a severe trauma, fall from the 3rd floor, like I've shown you, we always do a CT scan with contrast media. Yeah? But if you have probably a bicycle injury, and then it might be enough. But this is the next discussion, maybe.
I think that's probably also a good cue to move on to the next presenter. Paul, if you'd like to share your screen and start your talk.
Okay, thank you. And thank you to Professor Marzi. I'm trying to run through my talk then, and I'll start just to repeat that it's all about physiology, also when it comes to chest and abdominal injuries. And of course, you should have an algorithm including adjuncts during the primary and the secondary survey in children as well. And they're largely the same as in adults. When it comes to chest, it's actually easy because major surgical procedures are rarely indicated. 85 to 95% of children that need some kind of intervention, they're sufficiently treated by a chest tube. I'll show you a case. This is a sheet crash late in the afternoon. Actually, she was complaining of a severe chest pain, reduced the GCS, and actually the HEMS was activated, and they did actually an ultrasound on scene and diagnosed left pneumothorax. She came to the hospital 2 hours after the injury. A was okay, decreased the breath sounds on the left side, blood pressure of 93/59, and a pulse rate of 92. And just to tell you that I'm not able to remember all the values in the different age groups. So you should actually have some kind of memory. I have a plastified two-sided thing in my pocket where all the vital numbers in kids are represented. But it's not that bad. A GCS of 14 and E is okay. As part of the primary survey, we had a chest X-ray, and as you can all see, there are some pathology here. And based on what you can see in this chest X-ray, I have my first poll. So what would you do now? Transfer the patient to a pediatric trauma center, needle decompression, anterior chest wall in the second interspace, chest tube insertion in the fifth interspace mid-axillary line, or needle decompression in the fifth interspace mid-axillary line. So you can now submit your answers. And I guess that, Jonathan, you will actually give us the results. And as you can see, I don't think transfer to the pediatric trauma center is a wise decision if that's some distance away, because this is actually a patient that is trying to die in front of you. So you should do some kind of decompression. And again, depends on your institutional capabilities, but this is actually a real emergency situation. So if you remove that, yes, thank you. I'm not able to, okay, there. So in our situation, we had sedation of the child with ketamine, and then introduced the chest tube in the fifth intercostal space in the mid-axillary line. It's easy to do. It's a very short way into the chest. And I think that if you want to do a needle deflation first, then do it in the same region, because that's much easier to enter the chest and to keep that drainage open. So the patient went to CT based on severe pain in her back. But again, didn't show anything wrong within the chest, and she had some rib fractures on the right side, undisplaced, and she had on the left side an undisplaced left clavicular fracture. Just to remind you that if you have a completely normal CT, chest X-ray, and then you shouldn't do screening for pathology in the chest in children, because there is almost never anything that changes what you have decided to do. And in this patient, the findings did not influence on further course, which was uneventful. The patient went home on day 5. Just to end the debate whether you, after the acceleration injuries in children, need to take chest CT to screen for aortic injuries, and the answer is no. When it comes to pediatric emergency department thoracotomy, this is rarely indicated in children, at least in blunt trauma. This is a study by Allen at co-worker presented in 2015, and they looked into their own material and actually took all the published studies from 1980s and up to 2012, and they found actually no survivors in kids with blunt trauma and cardiac arrest under the age of 15. This was actually just verified by Moskowitz and co-workers in 2018 from Denver. They actually found the same results. And when it comes to blunt trauma, you should actually consider in the age group 0 to 14 years to avoid emergency room thoracotomy. When it comes to penetrating trauma, you should actually follow the adult guidelines. When it comes to the abdomen, if you have a child in hemorrhagic shock, as Professor Marzi mentioned, and the child is still hemodynamically compromised despite effective resuscitation, then that patient is not a candidate for a CT scan. Then this patient should be taken directly to the OR. And this is actually one of the patients we had many years ago, came in hemodynamic shock, was resuscitated, but still tachycardic, hypotensive, and had a positive fast examination, brought directly to the OR, and her spleen was removed. Most children with blunt trauma, they are hemodynamically normal or can be normalized, even though you suspect that they have an abdominal injury. And if so, if the trauma is adequate, then CT scan is indicated. Like if you have a child with a handlebar injury to the abdomen with a contusion mark, I'll show you a picture of that later on. That's, in my view, an indication for a CT scan. CT scan should not be used as a screening tool just to send people home or children home. This study from 2008 in the US, they used CT scan of the abdomen to send children home, and they had a negative score of 84%, which actually is a significant overuse of CT scan. Then, if in doubt, the children is not after clinical examination severely injured, then you can just observe the child, and if children deteriorates, then you can do a CT scan. Contrast enhanced ultrasound, still not good enough to rule out parenchymal injuries. You might use this as a screening tool in small injuries where you don't find that there is an indication for CT, but again, sensitivity and specificity is too low. Could be used as a screening tool, and if you have a positive FAST, then you should consider to do a CT scan. So, in a child with adequate trauma, taken to CT scan and an abdominal examination, you have actually three options. If you find a diagnosis like hollow viscous injury, then you take the patient to the OR. If you find a splenic injury, the patient is hemodynamically normal, then you will elect that patient for non-operative management. Sometimes you have to intervene, and that's actually, in most instances, angioembolization. But again, if you have a contrast blush in a splenic injury, a small contrast blush in a splenic injury in a child, if the patient is hemodynamically normal, you can observe. And if the patient deteriorates, then you can bring that patient, if you have the equipment and the competence, to the angio suite and do an angioembolization. In most solid organ injuries, like the liver, like the spleen, and the kidney, they should be treated non-operatively. Most centers, they report success numbers of more than 90% when you select your patient correct, and it's all based on physiology. If the patient is hemodynamically normal or can be normalized, then the patient is a candidate for CT scan and non-operative treatment. This was a child played soccer with his older brother and his comrades. Had a knee into his abdomen, came in, had a CT scan, showed a splenic injury, but he was hemodynamically normal, at least in the beginning, was taken to the ICU, and then he became more tachycardic. He needed a transfusion, and his hemoglobin fell over the next hours. So he was then taken to the angio suite, and he was then diagnosed with ongoing bleeding from his splenic vasculature, and he was then coiled both peripherally and centrally, and he went home on day 5. This is a major kidney injury on the right side, fell from 1.5 meter on the left flank, came in great pain, and actually a little bit hypotensive, was resuscitated, came to CT scan, as you can see, and it was ongoing massive extravasation. That patient was then brought to the OR and had a nephrectomy because the kidney was actually divided into 2, as you can see in this picture. I'm going to pay some attention on pancreatic injuries because that's actually the most controversial of the solid organs within the abdomen when it comes to children. Based on the study from Toronto in 1998, non-operative management in pancreatic injuries was highly supported, although in this study of 35 children, most of them actually had a long time to oral intake, and mean length of stay was actually 3 weeks. Still, they concluded that non-operative management of pancreatic contusion and transection is effective and safe. In our mind, it's all about whether you have a transected duct or not. Grade 1 and 2 should be treated non-operatively, but from grade 3 and on, there is an operate them primarily or just treat them non-operatively and then deal with the complications. So far, there are, of course, no randomized control studies because these injuries are not that frequent. And I'll show you a typical case, 7-year-old girl, handlebar injury. And as you can see here, it's not a scratch, it's a subcutaneous contusion mark. And she came in, was hemodynamically normal, but had abdominal tenderness and was vomiting. She was brought to the CT scan. And as you can see, you have a transection through the junction between the body and the tail of the pancreas. So my next poll is then, what would you suggest now? ERCP, close observation in the ICU, MRCP, or pancreatic tail resection?
And about half of the audience would go for close observation in the ICU.
Mm-hmm.
about a quarter would go for a pancreatic tail resection, and about the other quarter would either have an ERCP or an MRCP, which I presume is based on local resources.
Yes, it is. Okay. Close observation in the ICU, then you look for complications and you'll treat them. This patient wasn't in hemodynamic shock, so that's an option, of course. ERCP, in my mind, is not indicated because this is obviously a transection of the duct, and then the MRCP should actually be restricted to cases where you don't, based on the CT scan, can say whether the duct is transected or not. In our institution, and based on our experience with adults as well, we have another strategy. I'll come back to that later on. I'm trying to take the next slide, Jonathan. You probably have to unlock something.
I don't think so.
Okay. Oh, there we go. The biggest published study still so far is actually the patch study from the United States. They actually compared non-operative versus operative management in grade 3 injuries, the transection of the tail or the body to the left of the mesenteric vessels in children, and based on what they saw, they strongly recommended that operative resection should be done due to the fact that they had a much shorter time to initial feeds to normal feeding, and complication rate was much lower, and also length of stay in hospital. And I agree that the most important thing when you deal with pancreatic injuries is actually whether the pancreatic duct is torn or not. If it's not torn, then you can try to treat the patients non-operatively, deal with complications. But when you have transection in grade 3 injuries, we recommend spleen preserving tail resection, like in this case, as I've already shown you. We operated on that patient. Here is actually the pancreatic tail dissected free of the splenic vein. And then we drain for a short period, and this patient had oral intake on day 2, removed the drain on day 5, and was discharged home on day 7, which actually not unusual after pancreatic tail resections. Another patient is a 7-year-old girl, again, another handlebar injury. She had a subcutaneous epigastric contusion as the other one, and the same symptoms. As you can see here, she had a transection of the pancreatic head just to the right of the mesenteric vessels. We did laparotomy. We washed out. We just put in a drain in the lesser sac because we didn't want to resect the body and the tail of the pancreas, because we were then afraid that we would leave too little pancreatic tissue left. She had the enteral intake from day 2, had daily output from the drain up to 200 milliliter first week, then stopped over the next days. And then she was an outpatient patient for 2 days. We removed the drain, and she was formally discharged on day 16 and has had no further complications. Again, handlebar injury in a girl. All these cases were girls, but we have a lot of boys as well over the years. She was actually seen by a GP in her own community, and she was observed at home because she was actually doing fine. Then 9 days later, she was admitted to the local hospital due to increasing pain, anorexia, and vomiting. She had an elevated CRP and an amylase of 280. Then she was sent over to our institution, as you can see here, this is a CT scan of her abdomen, and what you might think is her stomach. This is actually a great cyst. The stomach is actually pushed anteriorly and superiorly, so there is no wonder that she has problems in eating and drinking. That was after 9 days, and based on our findings, we just did an upper endoscopy. She had an internal drainage. We put in 3 JJ stents from the stomach into the cyst, and she was actually discharged on day 3 in good shape. The cyst was reduced in size gradually over the next weeks, and we removed the stents without complications at the time of 3 months after the injury. At the end, I'll just make a short comment on whether you should treat penetrating abdominal injuries in children non-operatively or operatively. And this is a large study from LA, but based on the National Trauma Data Bank data, and they found that most children with penetrating injuries, they go directly to operation. A small percentage can be candidates for non-operative management, and the indications are more or less the same as in adults. Stab wound into the back, verified by CT that it's probably entering into the kidney, but with a small or non-existing hematoma around, it's a candidate for non-operative management. But as a rule, in most European countries where you see very few penetrating injuries to the abdomen in children, I recommend that you do a laparotomy. So, to conclude, physiology dictates, as Professor Marzi already told you, in all initial assessment of traumatized children. In the chest, major surgical procedures are rarely indicated. In the abdomen, liver, spleen, kidney should be treated non-operatively if the patient is hemodynamic normal or normalized during resuscitation. Pancreatic injuries, still a matter of discussion. There will be no randomized control studies. We feel that we are very comfortable with operating on the grade 3 and above. Laparotomy should be performed in children with a hemodynamic instability despite the resuscitation. If you find a diaphragmatic injury, laparotomy is indicated, or if you have a hollow viscous injury, including bladder rupture, the patient should undergo laparotomy as well. And most penetrating injuries are good candidates for a laparotomy. When you're treating children, and especially when you choose to treat them non-operatively, you have to look for complications over the first day, and you have to watch them carefully. And again, you should restrict CT to patient that is actually in need of CT scan, meaning that the trauma should be adequate, the symptoms should justify that you bring that patient to the CT scanner. It should not be used as a screening tool just to discharge patients. Thank you very much.
Thank you, Paul. That's a great overview of an in-depth overview, if you can have such a thing, of the management of thoracoabdominal injuries in children. I'd like to bring in Peter Schmittenbecher to comment first. Thank you for joining us, Peter.
Hello, good evening. I think the most important thing is, and Paul told to us very exactly, there is nearly no planned injury which needs surgery from the first moment. We always can think about and reflect the conservative options in these children, And we know from the colleagues from Toronto that especially in spleen injuries, it's possible to manage conservatively nearly 98% of all cases, including the polytrauma cases. So we have really a big chance to save these organs. And if we have an unstable child and we have to do the laparotomy, it's important to look for packing options and not to put out the organ too early and too fast, because the spleen function is very important for the children.
Thank you. Ingo, do you want to comment on the use of CT?
Yeah, this is the question. The use of CT, this was never discussed here, like you have shown in the American study that the CT could be used to discharge children. I think this is out of any reality. I think we have rather the discussion if we should use the CT scan, and we have it particular with the colleagues of Peter Schmittenbecher, the pediatric surgeon. So sometimes if the ultrasound or the FAST of the abdomen, if he shows some blood, some injury, but the patient is stable, if we still should perform a CT scan with contrast media. And the discussion is always, if a small children falls, if you only perform a CT scan and a thoracic chest X-ray and a FAST of the abdomen, if this is sufficient, or if there's adequate trauma just to perform the CT scan. And this is an ongoing discussion. So I don't know how you handle this part.
Again, it's partly based on physiology. If the patient is hemodynamically stable, then you, of course, you take the history. What's actually the mechanism of injury? If you have a handlebar injury with a contusion mark, I think that's an indication for CT. Just to, because you might have a retroperitoneal injury to the duodenum or to the pancreas, and you can have very few symptoms from the beginning. So I think that's an absolute indication for a CT scan. But a lot of children, they fall on the ground, they're playing, they get some minor trauma to their abdomen. But again, based on the initial assessment, if the patient looks fine, there is actually no or very little tenderness, then you can just observe that child. And we don't use FAST in these children because we don't, then if they're okay, there is so much insecurity with the FAST examination for solid organ injuries. So we just observe them. And many of these, they can just leave the hospital the next day. But again, if based on the history, on mechanism of injury and your clinical evaluation, you find an indication for CT scan, then you do it. And then you do it an appropriate CT scan, I think. Don't try to reduce the radiation dose to very minimum, because then you end up with an inconclusive CT scan, and then you have to repeat it if actually the symptoms goes on. But again, I think it's valid to say that you should have a discussion in every case if you are in the gray zone. Most of them, they're easy to say, just observe, or just it's obvious that this patient needs a CT scan, and then you have a gray zone, and these patients, you can discuss them within your trauma team and with your colleagues, and you will then find, I think, the reasonable solution.
Yeah, I think that's the way, but you're right, we are also rather on the side to rather perform a CT scan with contrast media if there's any doubt, because sometimes what you mentioned, duodenal or small bowel injuries, you don't see with the ultrasound or others. You see clinically after a day. But sometimes in CT, you see very early some fluid in this area, and then you are earlier. So, so if the trauma is adequate, we use a CT scan with contrast media. But in some cases you discuss it and you observe it. But one's different in our trauma room. Every patient, adult or children, gets an ultrasound fast within first 3 to 5 minutes. Yeah, so it's just routine. Yeah.
The long time discussion was, do we need a CT scan in every child coming in the emergency room? And there our answer was no, because we have a lot of children which have a head trauma and perhaps a femur fracture, and they don't need a CT scan from the head down to the feet. But if we have a relevant abdominal trauma or thoracic trauma, absolutely no doubt that we need a fast CT scan to know the injury exactly and to plan our treatment.
Well, I've got some tough questions for you from the audience. The most difficult one we'll start with is with a combined pancreatic and duodenal injury, how would you manage it?
Do as little as possible. They're extremely rare in children, and I've actually had just one severe case, and I've had some severe pancreatic cases and some duodenal, but combined, again, make it simple. And I think if you are in a smaller hospital and you have to do, because this is a patient that comes in with peritonitis or in shock, and you operate on that patient, do as little as possible. Do damage control, send that patient to a pediatric surgical unit, because very often when you go in the next time, you see that the duodenum can be easily repaired. You can just suture it with a primary suture, and the pancreas, because then there is actually an injury to the head, is very often only a contusion. And even though it should be actually an duct involvement, we just drain them. And that's the end of story, actually. Then you have to be patient. If you have a major duct, you have a grade 4 or a grade 5 injuries in children are extremely rare. But if you have, like I showed you, a grade 4 injury, pancreatic injury in a child, you drain them, and you just tell the parents that they can actually drain for weeks. They should be prepared for that. But in the end, they dry up and problem is solved.
And how do you feel about stenting the pancreatic duct in proximal lesions?
We don't do it, and you can read the case reports, but the pancreatic duct in a 4-year-old child is very small. So if you actually have a real transaction where you have actually a distance of 1 centimeter, but you should have more than luck actually to be able to pass the guide wire into the distal duct. So we don't do it, and we don't do ERCP because we are afraid of actually making further complications. So if you are in doubt whether the duct is transected or not, we do an MRCP, and we have very good quality of that intervention. We can conclude in almost all cases whether you have an intact duct or not. And if the duct is then transected, then we operate. And again, either tail resection, body resection, or just drain. And if it's not an injury of the duct, then we just observe.
Okay, what's the value of microhematuria? Would you use that as an indicator for CT scan?
No, we don't.
I knew that would be a simple answer.
But in this respect, I have one proposal, what we introduced in our trauma management. If we have a CT scan, with contrast media, then you make just a normal image 20 or 30 minutes thereafter, and then you see the whole urinary tract system. Yeah, so you don't need some extra things. Yeah, so in severe trauma, you can see it later on very easy.
Yeah, we always, if we suspect anything from the urinary tract, we have a late phase, and we have this 10 to 15 minutes. That's the pediatric protocol in our unit, and then you will see whether you have actually some significant injury or not.
But if you have a relevant trauma to the kidney, you have more than micro hematuria.
Either you have actually a transection of the ureter, which is actually extremely rare in blunt trauma, but in most instances you have an intact ureter, and then you have hematuria, as you say. And we use macrohematuria as an indication for a CT scan.
All right.
Okay. You didn't mention the laparoscope in your presentation. Would you use that for cases where you suspect a hollow viscous injury?
We don't, because if we have a patient that is a candidate for surgery, we find that it's so rare, and we are so afraid of missing small injuries, so we go directly to a laparotomy. But you might consider it because we see from time to time, although not in small children, but in teenagers, that you have penetrating injuries to the chest, and you suspect that it might traverse the diaphragm, or you have it in the flank. You might suspect that it may be a peritoneal breach, and then we do a laparoscopy to see whether you have actually an injury that goes into the abdominal cavity. And if we find that, then we convert. That's our protocol, but people might have another way of treating that, but we feel that this is the safe way of treating children as well.
Okay, thank you. And for the final question to you, which is a nice easy one, post-splenectomy vaccinations, do you do them, and if so, when? Yeah,
we and again, as Peter said, splenectomy in children are actually very rare. So but we follow the national recommendations, so they will be immunized, and we do that a week after splenectomy, before they leave the hospital, because then we are actually sure that they will have their vaccination, and then they have to be followed by the GP, so to say. And depending on the age of the child, we might also consider, based on the recommendation from the pediatricians, to put them on oral antibiotics.
Yeah, penicillin prophylaxis for nearly 2 years, I think, is the actual recommendation from the pediatricians.
Okay, thank you very much. Thank you, Paul. I think it's time to move on to Thomas and your presentation on management of extremity injuries. So Thomas, if you'd like to share your screen.
Yeah, thank you very much. I will. There we go. Okay. So thank you very much, Jonathan. So finally, we talk about the primary stabilization of extremity fractures. Extremity injuries are common in the polytraumatized children. However, and Professor Marzi already showed a slide like this and a graph like this, we know that the extremity injuries that play actually a minor role when it comes to the survival of the multiply injured child. However, extremity injuries play an important role when it comes to the long-term outcome and quality of life. In a big retrospective study using the German trauma registry, the authors actually nicely demonstrated that the rate of extremity injuries, and you see it here in the red and orange line, that the rate of these injuries increases with the increasing age, and that lower extremity injuries are more common than upper extremity injuries. And this is over all age groups seen. Extremity fractures have to be seen in the overall context of the injury pattern of the polytraumatized child, and as well, of course, in the context of the hemodynamic status of the child. Without any doubt, control of life-threatening injuries, let's say intrathoracic, intracranial, or intra-abdominal injuries, this is the first line of treatment, of course. However, emergent treatment is also relevant for open fractures, for example, or for fractures with associated vascular injuries. in case of compartment syndrome or for amputation injuries. One point that I really would like to mention is that it is very important that children often recover remarkably well from injuries that we think that they look initially really devastating. So I think the treatment of the extremity injuries should always be done in the expectation that the child will fully recover. And if possible, the initial treatment should already be the final treatment. In particular, injuries of the lower extremities, operative treatment might be more beneficial because this will allow a better mobilization and position changing in the ICU, but also for rehabilitation after the hospital stay. The management and the prognosis of open fractures and soft tissue injuries in children differs a little bit from when we compare it to the management, what we do in adult patients. First of all, I think the infection rates in open fractures are lower. You see it here in this study that was done in more than 550 open fractures in children. You see that the infection rate was ranging from 2 up to 8% in type 3 open fractures. And what is interesting, actually, the infection rates, they do not really differ comparing the different time to first debridement. So this is a little bit different when compared to the management in adult patients. And what is also important, in children, the initial surgical debridement should not be performed in a radical way as we do it in adults. Tissue of questionable viability can really initially be preserved because children have a much better healing potential. And also bone fragments, which is maybe stripped of soft tissue and periosteum, these can also be retained because this will be still incorporated into the callus. What is, of course, important is that we stabilize the fracture to protect soft tissue. This will also reduce the pain and will facilitate rehabilitation, which is very important. So let's first start and look at the fractures of the lower limb. Femur fractures, open or closed, they will, in the polytraumatized children, in most cases, in almost all cases, require surgical stabilization. The same is also true for tibia fractures, which will require surgical debridement if they are open, so a surgical debridement of the soft tissue injury, and will also require fracture stabilization. Closed tibia fractures can in some cases also be immobilized first in a cast, and then if surgery is performed, as soon as the condition of the polytraumatized child will allow this. Fractures around the ankle can, I think, in most cases first be reduced and then splinted, and the surgical anatomic reconstruction can then be done as soon as it is acceptable. Let's have a closer look at the femur fractures. As I already said, I think in a polytraumatized child, each femur fracture should actually be seen as an indication for operation. For the femur shaft, we have several standard implants, and these are the external fixator and elastic stable intramedullary nailing, so ESTES. And Timothy already told me that actually they are known also as the Nancy nails. So when I talk about ESTES, I actually think of Nancy nails. And then we also have implants like intramedullary nailing, so the rigid intramedullary nailing and the plate osteosynthesis. But in my opinion, these are really or should be exceptions, or in children with a higher body weight or in adolescent patients. Let's start as well with the external fixator. External fixation is generally indicated in fractures associated with polytraumatized injuries and in fractures with extensive soft tissue or neurovascular tissue damage. When looking at the fracture pattern, external fixator is indicated in comminuted fracture, in multifragment fractures, in long and unstable oblique fractures, and as well in specific metadiaphyseal fractures. This can you also see on the next slide here. In these metadiaphyseal fractures, but also in very distal fractures, the external fixator might be actually the safer treatment option, but you do not have a 3-point stability as you have it with the ESTES. And these are here the elastic stable intramedullary nailing, the Nancy nails. They actually work with the concept of 3-point fixation. And with this 3-point fixation, they provide quite a good stability. However, it is not a rigid stability. There is some micro movement that leads to an early fracture healing and callus formation. And additionally, ESTES allow a closed reduction, which preserves actually the fracture hematoma. So the ideal fracture types for ESTES are transverse fractures of the shaft and short oblique fractures of the shaft. This is shown here, some examples of intramedullary nailing of typical femur fractures, a transverse fracture on the left side and a short oblique fracture on the right side. But you can also use the ESTES for very proximal femur fractures or trochanteric fractures. Distal femur fractures can likewise be addressed with Nancy nails. In the case on the right side, an antegrade insertion has been used for this distal femur fracture. Also, here you see the antegrade insertion, and you also have to carefully look that you have a maximal nail spread at the fracture site. This has to be achieved. Only then you will have a good fracture stability. When we compare ESTES and external fixator, both methods actually require a minimal surgical exposure. But one of the disadvantages of elastic nailing is that it might come to a shortening in length, unstable or in comminuted fractures. However, when we use the available end caps, I think even unstable spiral fractures may be sufficiently stabilized. The infection rate and the refracture rate following ESTES is low, but it's quite difficult to change the concept or to do a secondary reduction after insertion of ESTES. The external fixator is technically more easy to perform. However, it carries the risk of pin site infection and refractures, and this is in particular seen in transverse fracture. And it is more easy to change the concept or to perform actually a secondary reduction. Fractures around the knee are commonly seen in the polytraumatized patients because these are typical injuries following in a high energy trauma. These type of fractures or epiphysiolysis, they will typically require an anatomic reduction initially and a stabilization using screws or cannulated screws or K-wires as soon as possible. What is also important to mention is that the distal femur fracture or epiphysiolysis, they are sometimes ventrally dislocated and they are difficult to reduce. And there is also the risk of a vascular injury caused by the dorsal rim of the femoral or tibial fragment, as indicated with the red arrows. With regards to the tibia shaft fractures, I think the casting still plays an important and a major role in the treatment of these fractures. However, it is also important to mention that I think fixation, surgical fixation, is beneficial in children who have sustained multiple injuries or those with head injuries, because this will allow early mobilization. Indications for surgery include unstable fracture patterns, an unacceptable closed reduction, of course, open fractures, compartment syndrome, but as I already mentioned, polytraumatized children, because this will allow early mobilization in ICU and in the rehabilitation. These are here some examples of typical tibia shaft fractures. You see an undisplaced fracture here on the left side, which was treated in a 5-year-old girl conservatively with a cast. Then, of course, open fractures, which were treated with an external fixator. And as I already mentioned, the ESTES, in this case on the right side, actually it was complemented as well with 1 week of a cast. It is important for the external fixation as well as for the ESTES that we really try to get the correct axis and to avoid a recurvation in this type of fractures. Now we proceed to the distal tibia fractures and the fractures around the ankle. In these type of fractures and epiphysiolysis, I think in most cases we can do a closed reduction and cast in the initial acute management, and as soon as the conditions allow, and if I think it's also something that we have to discuss and you have to decide case by case, then as soon as possible do the closed reduction and K-wire fixation, or in some cases as well using a screw. So this is now a case that I would like to show. This is the first of 2 cases. The first one is the case of a 3-year-old girl after a fall from the 3rd floor on hard underground. She arrived hemodynamically stable in the emergency room, presented clinically an unstable right upper leg. So in the box you see the injury pattern, which we found after the initial assessment in the shock room. The girl suffered from multiple tooth luxations, dislocated mandible fractures, a chest trauma, and the fractures which you see on the X-ray on the right side. So my question now is, how would you manage this femur fractures in the initial phase, in the acute phase? Would you do it conservatively? Would you put on an external fixator on the shaft fracture and leave the proximal femur fracture alone, so you do not touch this one? Or would you use an external fixator for the shaft fracture and screws for the proximal femur fracture, and ASIN for the shaft fracture, screw for the proximal femur fracture, or would you choose other procedures? So I think I will get the results very soon.
Polling always takes forever, but here we go.
Okay, so most of you would put in ESTES or Nancy nails for the shaft fracture and screws for the proximal femur fracture. I think this is absolutely a good option. And 32% would use an external shaft, an external fixator for the shaft fracture and screws for the proximal femur fracture. So 1/3 would do this, and actually 2/3 ASINs and screws. I show you now what we did. Actually, we did both of it. Let me proceed here. I cannot proceed, but maybe it comes.
I think you're having the same problem that.
Yeah, I have the same problem. I cannot.
It'll happen eventually.
Yeah, I hope so. Not yet. No. Let me see here. Okay, now it works. So you see, in the initial phase, we use the screws for the proximal femur fracture. It's actually we see it's a Tilsed type 3 fracture, which was reduced in a closed way, and then the screws were put in. And for the femur fracture, we initially put on an external fixation. This is, I think, an acceptable treatment option, especially if you want to have it quite fast. The external fixation is faster than ESTES, I guess. And then after a few days, we changed to swell closed reduction, and we put in the ESTES. I think it also depends, of course, on the experience of the surgeon. If you can put in the ESTES quite fast, this is, of course, also an option to do this right away in the initial management. So this here is a second case of a 11-year-old boy which suffered a subway accident. He fell between the platform and the incoming train. He presented clinically stable, and most impressive, he showed these open fractures, and as you see, a very severe soft tissue injuries actually on both lower legs. So here again, the injury pattern, which you see, he had an open TBI with skull impression fracture. He had a femur fracture on the right side with compartment syndrome, a subluxation in the ankle joint on the right side, as well with this extensive soft tissue defect. And on the left leg, he had a 3rd-degree open comminuted tibia fracture, as well with this extensive soft tissue defect that you saw. And of course, we went with this boy to the OR. There was debridement of the soft tissue wounds done, a decompression of the acute compartment syndrome on the right thigh, and the neurosurgeon put in an intracranial pressure monitoring. And here again, my question: how would you manage now the femur fracture and the bilateral lower leg fractures? So would you put on an external fixator for the femur and external fixators for the bilateral tibia, ESTES, Nancy nails for the femur, external fixator for the tibia, both ESTES, femur, and bilateral tibia, or would you choose another management? Okay, I think the result is very clear. You would put on external fixators for femur as well as for both tibias, and this is, of course, what we did. I think this was actually the only option in these with these severe open fractures and soft tissue injuries. Here you see the post-operative X-rays. The soft tissue defects on both sides were covered with Syspoderm, so synthetic skin substitute. And in this patient, the external fixator was for the femur was actually changed to Nancy nails ESTES a few days later, and the external fixators were kept on both lower legs, on both tibia, and the soft tissue defects had to be covered with latissimus dorsi flap on both sides after multiple debridements. And this is something that I already told you, the correction of a rotation or a correction of a reduction is much easier when you put on external fixators, and this actually had to be done on the left side. So for the final few minutes, I would like to talk about the concept for upper limb fractures in the polytraumatized patients. In isolated injuries of the proximal humerus, the conservative treatment still has, depending on fracture dislocation and age, still a great importance. However, in the polytraumatized child, I think an unstable shoulder region might be a problem for intensive care treatment and early mobilization. Therefore, surgical treatment might still be necessary, for example, using K-wires or an ASIN inserted in a retrograde fashion. However, in children under, let's say, the age of 10 to 12 years, the indication for a surgical treatment really should be checked very critically, because the conservative treatment will also result in many cases in a good outcome as well, and mobilization following the operation might not be that much faster as compared to a conservative treatment. When we look at the humerus shaft, indications for surgery include fracture displacement on the one side, soft tissue injury, so open fractures, A radial nerve palsy alone, I think, is not really an indication for surgery per se. And again, in the multiply injured child, having the critical care and mobilization problems in mind, operative treatment really might be beneficial in these cases. Undislocated injuries of the elbow can be immobilized, I think, in the acute management in a splint. However, for unstable type 3, type 4 supracondylar fracture, as you see one case on the right side, even in the polytraumatized patient, this is clearly an indication for operation. And the most often technique used here is closed reduction and fixation with crossed K-wires, as you see here in this case. However, the disadvantage of this method is that you will need still a cast postoperatively. Therefore, in some cases, it might be also an option to use antegrad ASINs or an external fixator in the multiply injured child. Let's have a look at the forearm and wrist fractures. In unstable forearm fractures, shaft fractures, the indication for surgery, I think, is clearly given also in the polytraumatized child. Initially, however, the fracture can be reduced and immobilized in a cast, and as soon as the conditions, the hemodynamic status of the child will allow surgical treatment is recommended. This will then allow cast-free mobilization, and the method of choice, I think, in this type of injury is clearly the ASINs. And finally, we come to the distal forearm and wrist fractures. Also, the correction potential in distal forearm fractures and wrist injury is high. I think there is the option still of doing some of these injuries in a conservatively way, depending on age and grade of dislocation. However, I think in older children and in adolescents, surgical reduction and mostly fixation with K-wires will still be necessary and will also avoid a secondary dislocation of the fracture or epiphysiolysis. So in summary, due to this special situation of the polytraumatized child with the requirement of an intensive care therapy with frequent changing of the position and also the goal of an early mobilization of the child, indications for operative stabilization of extremity fractures should be quite wide. Basically, each femur fracture, in my opinion, in a polytraumatized child is an indication for operation. Fractures of the lower leg, upper arm, forearm should be evaluated case by case. However, early mobilization and weight bearing should, I think, be the goal in these patients. Thank you very much.
Thank you, Thomas, for that great overview. Ingo, do you want to comment on that as our...
Yeah, actually, I think most procedures are very nicely presented, and also I think the current status of treatment and the difference from children to adults is a little bit, I think that in adults we have a two-step procedure that we make external fixator and later final osteosynthesis. This seems in children rather not the case. Usually we try to make in one step. What do you say?
Yeah, I absolutely agree. I think this is when we look at studies, we see that in the younger children we actually use much less damage control procedures compared to adult patients. And I think it's important that we really try to do the final treatment already in the initial phase of the management. I absolutely agree. And we also see in the studies that this is doable. So there is not a worse outcome if we do it initially in a definitive way. So we really actually think can do it safely.
Peter, you're agreeing there.
Yeah. I have another question. So usually if we have a supracondylar fracture in the children, usually we do it immediately in the first hours. Yeah. But if you have a polytraumatized patient, you do not do anything between. You just put on a cast and do it the next occasion, or?
Yeah, I agree. Yeah, I think it depends a little bit on the conditions. If you can do it safely in the initial phase, I think we should do it. Otherwise, if it's not safe from the condition, from the hemodynamic status, I think put on a cast, immobilize it, and do it as soon as the condition allows.
I think I'll ask a question which will get my UK orthopedic colleagues very jealous, but how long does it take you to get these patients to theatre from the time they arrive in your hospitals?
Yeah, I think it of course it depends on the severity of the injuries, on this of the status, but sometimes it can take some time. I agree. It depends. It really depends on the case and on the situation you are. That's difficult to answer.
As a ballpark figure, how long would you expect normally?
Well, if you go directly from the shock room to the OR, I would guess until start of the procedure, it still will take 60 to 90 minutes, actually.
Okay, as I said, my colleagues will be jealous. And if you have a case that you are taking back to perhaps where you've changed an external fixator for internal fixation, when would you get that patient back to theatre? When would you do that procedure?
So if you really, I mean, we also have to consider that external fixation sometimes really can be the final treatment. Mm-hmm. As I showed you as well in this one case with the severe soft tissue injuries. But if you really want to change it, if you want to change the concept, I think it's first of all, again, look at the status of the child, discuss it with the intensivists, discuss it with the pediatricians. And as soon as it allows, I think you can do it. But basically, I think it will be around day 5 to 7, something like this.
Okay, thank you. Anybody else? Peter, you look like you desperately want to comment on something.
What I want to say is there are two important things in the discussion about the fractures. The fractures are seldom or nearly never in the foreground, but the pain may be in the foreground if the children are conscious. So we need always a very good pain management in the emergency room, and to look to make the situation a little bit better for the children. And the second, Thomas showed us two methods, external fixation or intramedullary nailing. Both are perfect for a lot of fractures. And it's my opinion always, do the method in a polytrauma case you are most familiar with and you are fastest with to stabilize the children, to get it out of the OR. And don't try to make it with a method you are not so perfect with. So if you're a fan of external fixation, do the external fixation, and as Thomas told us, this may be even the definite treatment. We don't have to change it in a lot of cases. And if you're very fast ASIN stabilizer, you can do the ASIN even in the polytrauma child.
Yeah.
Okay, thank you. Paul, do you want to comment at all?
No, I had a feeling that what you were actually asking, Jonathan, was that children were often not prioritized, so they had to wait long for actually coming into theater. Am I right? Because at least in our hospital, we have separate operating theaters and teams for kids, and if they're going to do a second procedure, then we'll do that as a day time procedure. So they are prioritized and have actually a very smooth paths through both the first and second procedures.
Yeah, I think I was a little bit unfair to my colleagues because children are usually prioritized, certainly over adults, but it's trauma burden that's the problem, being able to get all of those into theatre.
Mm.
Okay, I think this is probably a very good time to look at drawing the webinar to a close. I hope that you have enjoyed it, that you found it useful. We have a great backstage team who have put in a lot of effort and without whom this would not be possible. So I'd like to take the opportunity to thank my good friends, Diego Mariani, Alan Biloslavo, Hayato Kurihara, and Mauro Zago. To thank our fabulous panelists, Ingo Marzi, Paul Ness, Thomas Lustenburger, and Peter Schmittenbecher. Thank you for joining us. I hope you've enjoyed this webinar and will join us again in 2 weeks' time for an ESTES webinar on point-of-care ultrasound, where the panelists will try to answer the question of whether it really can improve acute surgical practice. And in 4 weeks' time, we'll be having a webinar on the management of periarticular injuries around the knee. Details of these and all future webinars can be found on the events page of the ESTES website at estesonline.org. Hope to see you then. Thank you for joining us. Goodbye.